you don't have to worry about, you know, sharp or dull. It's just, I think ice is a great way to do it. Hopefully that answered your question. Yes?
What about alcohol swabs?
Sure, you can do that, but the problem with that is that once you swab it a couple times, it basically gets right up to body temperature. It loses that cold feeling. Ice doesn't do that. Ice melts, but you can always get more ice. Yes?
Can a patient go upstairs as you're seeing the spinal wear off? I mean, it's wearing down as opposed to anywhere else. When can the patient safely go upstairs, do you think? When you start to see it go down, or when are you going to have your pressure drop?
Well, I think once it's starting to wear off, you're certainly in less danger of the pressure falling. But this is where the PACU nurses are worth their weight in gold. You know, your assessment of that patient is what I rely on. If it's a young, healthy patient, absolutely. You know, an ASA1 patient, there's really no reason for you not to send them unless you get a funny feeling about it. And when I say funny feeling, this is going to sound strange, but when I'm working with some of you guys in the PACU, I mean, fantastic nurses, you guys have been doing this long enough to know you get a clinical feeling for patients, and we really rely on that. It's almost like a sixth sense, you know. If you get it, once you do this long enough, you'll know what I'm talking about if you don't already. But that's where you guys really help us out. If it's an older patient you're concerned about, it's wearing off, but you know what, I just don't have quite a wonderful feeling about this, hang on to them and wait till you're more comfortable. That's not really a very good scientific explanation, but anybody else? What time is it?
It's 10 after.
Oh, awesome. I got an 8:30 surgery, so, but I have plenty of time if you guys have any other questions. You guys just want to sit here and look at George, huh? Yes?
Scott, one of the things that helps us with PACU with respiratory depression to counterbalance it is putting Narcan and AMP into a liter of fluid. Would you talk to the floor staff about that concept?
So you're talking about for respiratory depression?
Mm-hmm.
Sure. So in patients that, you know, Narcan, what narcotics do is they hit the mu receptor in the central nervous system. And the mu receptor is responsible for many different things, one of which is pain. The other, though, is that it affects respiratory rate. And anytime you have a narcotic in the central nervous system that's hitting that mu receptor and so forth, you can really get some respiratory depression. Narcan, what it does is it binds to that mu receptor, basically knocks off the narcotic. The problem with doing that is that it wears off. And if you're really concerned about a patient that has respiratory depression, and once that Narcan is gone, can go back into respiratory depression, you really have to watch it. Now with fentanyl, which goes away quickly, which is lipophilic, it doesn't stay in the CSF, in the fluid which surrounds the central nervous system. It's not such a big deal because it goes away. With morphine, that is an issue, so you really have to watch that. So I guess my answer would be just be aware of which narcotic you're given, which narcotic they've gotten in the spinal. And it's, you know, if as long as everyone that's taking care of that patient is aware, they can have morphine on, and you can do that with Narcan or naloxone. Just make sure that every single person that's taking care of that patient knows that once that Narcan is gone, they can go back into a respiratory depression, and maybe have a plan in place that once that bag is gone, you got another one ready. So
That's the issue. I think that when we send them up, I try to remind people that you need something for 24 hours because of the effect of the, for instance, Duromorph.
right, and again, the time frame you really have to worry about is 12 to 16 hours after that, usually about midnight.